Hello my friends, my name is Dr. Saeed Kazmi. You're watching my YouTube channel, and in today's video I'm going to talk about pediatric heart failure. Now, pediatric heart failure is different from the adult heart failure. I mean, if you visualize an adult heart failure, you probably think about an old man who has gotten years of perhaps smoking, high blood pressure, has got a deranged lipid profile, and then you visualize that this person to be having exertional dyspnea. This person actually is like, he catches his breath when he takes a few steps, or is basically very difficult for him to go upstairs without like losing his breath. And whatever he does, he feels tired and he easily gets out of breath, or sometimes when he sleeps, he cannot sleep in a recumbent position because he gets breathless. So basically that's the picture that comes into your mind when you thought about an adult heart failure. Pediatric heart failure is different in this respect, because pediatric heart failure basically presents with symptoms that point towards another direction. Basically, it's very difficult to pick up pediatric heart failure, because the symptomatology is so weird, it's so non-specific that you do not think of an underlying heart problem. So we will be talking in this lecture, we'll be talking about pediatric heart failure, its definition, the classification of grading its severity, the medical management, as well as the latest surgical management. So to start with the definition, basically the definition of pediatric heart failure is that it's a sort of a syndrome. It's a condition in which the heart is not able to pump blood in amounts that basically satisfies the needs of the body. In other words, the cardiac output is inadequate to meet the metabolic demand of the body, or if it is doing that, it is doing at elevated filling pressures. In other words, the heart has got a lot of strain to do its job. So that is what is the basic definition of heart failure. Now, pediatric heart failure, basically, if we look why the heart fails, we can classify all the causes in three umbrella terms, and those umbrella terms are described as pump failure, pressure overload, and volume overload. Now, what is pump failure? Pump failure, basically, pump is the heart. So basically, if there's any problem with the heart in itself, like for example, the heart muscle is damaged because of inflammation like myocarditis, or because of infiltrative conditions, then the heart is not able, like for example in different types of cardiomyopathies, then the heart is not able to pump the blood, or that would be a pump failure. Then we've got the pressure overload condition. The pressure overload condition simply means that the afterload is very high. In other words, the pressure against which the heart has to pump blood, that pressure is very much elevated. For example, in certain types of aortic stenosis, supravalvular aortic stenosis, coarctation of aorta, systemic hypertension, things like that. So the heart has to pump with a lot of force. It has to work very hard to pump against these elevated pressures, and that we call as a pressure overload condition. And over a period of time, obviously the heart would not be able to pump against these pressure and it would start failing. The third one is what we call as volume overload. And volume overload is that condition in which the heart is receiving too much of the blood, and we call it increased preload. Now, basically, it's not the volume of the blood that has increased in the body of the child, it's basically the amount of blood inside the heart. And these are the conditions, basically congenital heart conditions, which are causing left to right or right to left shunting of the blood. So one side of the blood is getting too much of the blood than it can handle, and that leads to elevated filling pressures, and obviously over a period of time would lead to stretching of the heart muscle, which might be reversible in the initial stages but can become irreversible later on and can cause heart failure. So in all these conditions, where eventually what happens that the output is not able to meet the demands of the body. So when the output is reduced, what would happen? The body would try to compensate is by activating the sympathetic nervous system. That causes tachycardia, that causes tachypnea. At the same time, it activates the renin-angiotensin aldosterone system, the RAAS system, which causes sodium and water retention, and that would lead to overall volume overload that further aggravates the condition and can lead to symptoms like breathlessness, can lead to edema, things like that, which happens more in the adult, but in older children that can also happen. So basically, the cardiac failure occurs because of either the pump overload or the pressure overload or the volume overload. Now, the etiology is very much in children is age dependent. In the very young infant, it's mostly the congenital heart defects, like congenital heart defect, for example, a VSD and an ASD, patent ductus arteriosus, complex congenital heart diseases, which cause like left to right or right to shunts. So these would cause basically volume overload, and over a period of time, the heart can fail. So most of the causes of pediatric heart failure by statistics, they occur in the early age, and majority of them are because of congenital heart defects. Sometimes it can also be acquired, like for example, viral myocarditis, which can occur because of Coxsackie viruses, cause inflammation of the cardiac muscle, presents like bronchiolitis like symptomatology, and that can also cause heart failure. As we move along the age spectrum, then the acquired causes, like for example, acquired cardiomyopathies, restrictive cardiomyopathies, dilated cardiomyopathy, hypertrophic cardiomyopathies, all these different types of cardiomyopathies, or drug acquired or immune mediated damage to the heart, they come into play. So older children have got a different set of etiology as compared to the etiologies that we see in the younger age group. Now, the presentation is what we call as the chameleon, because unlike adult presentation, where they usually present with exertional dyspnea or difficulty in breathing, which is aggravated by exertion, pediatric age group patients, they do not present with that. It's usually in children in the very young age, where most of the cases of pediatric heart failure occurs. They mostly present with feeding difficulties, and any child who has got feeding difficulty, who takes longer to feed or breaks in sweat while feeding, or in simple words, if any child who has got more than 40 minutes to feed and you have excluded feeding issues, you have excluded other things, then you should be start thinking of heart failure. So any child who's got feeding issues in absence of other like plausible effects and is combined with tachycardia and tachypnea. So tachycardia can occur because of so many conditions like fever and things like, but in these kids, there is no fever. There is no other possible explanation for tachycardia. They also got tachypnea, that is elevated respiratory rate. But again, the chest is mostly clear. So if a child who's got tachypnea and tachycardia with no obvious explanation, and they also have got difficulty in feeding or taking longer time to feed, then you should start thinking of pediatric heart failure. So in the very young age, they present like this. In the older age group, then they present mostly with gastrointestinal symptoms. So what happens, because there is systemic venous congestion, because the heart is not able to pump. So what happened, there is mostly the edema of the intestinal organs. So there is edema around the stomach, around the intestines. So these kids mostly have got loss of appetite. They do not eat very well, so they start faltering on their growth curves, because at the same time the demands are high, because the body has got tachycardia and tachypnea, but the child has got anorexia. He's got less feeding because there's edema around the intestine that causes loss of appetite. Sometimes this edematous stomach or intestine can also cause vomiting. So intractable vomiting, intractable upper abdominal pain, where you have excluded cause, might be because of this congestion of the organs, which is caused in pediatric heart failure, especially in older children. Then if you move further along the age spectrum, like the adolescent or something, then they present more with adult-like symptoms. For example, difficulty in breathing while exerting themselves, or like certain signs of heart failure, like for example elevated JVP, congested lungs, and sacral or pedal edema. So that mostly occurs in the older age group. Now, as far as the grading of severity of heart failure is concerned, in adults, we use the NYHA, that is the New York Heart Association classification. In pediatric age group, we use the Ross classification. And Ross classification is easy because it actually ties the three cardinal signs of heart failure, that is tachypnea, tachycardia, and feeding difficulty. So there are, just like you have got the NYHA 4 categories, like 4 classes, we have got the 4 Ross classes. Class 1 is asymptomatic, where there is heart failure, but the child is asymptomatic. So there will be no tachycardia, no tachypnea, and no heart failure. It can only be detected on echo or some form of investigation. Class 2, which is mild, basically there is mild tachypnea, mild tachycardia, the feeding is prolonged, and the child takes somewhere between 20 to 40 minutes on feeding. And in older children, they might be having some mild dyspnea on exertion. The class 3, which is considered to be the moderate heart failure, there is marked tachypnea. So like the respiratory rate would be quite high, the heart rate is quite high, and feeding is more than 40 minutes. But in this particular case, the feeding is prolonged, and at the same time the child is growth faltering. In category 2, that is mild, there is no growth faltering, though the child has got feeding issues, but there is no sort of a deceleration on the growth curve. Here there is. And class 4 is actually where the symptoms are present at rest as well. It's tachypnea, retractions, grunting, marked growth failure, and obviously the child takes longer than feed. They constantly are breaking up in sweats. And in older children, they have got not only symptoms of aggression, they've got symptoms at rest as well. And this class 4 category basically correlates very well for the need of transplantation or ventricular assist devices. As far as the diagnosis on biomarkers is concerned, now we are seeing an increased role of the BNP in children. It is used in adults because it is very specific to the cardiac myocytes, but the anti-pro BNP, that is the N-terminal peptide pro beta natriuretic peptide, that is very much specific to pediatric cardiac myocytes as well, and we are seeing that there is an increased role of this thing as a biomarker for the severity of the heart failure as well. Now kids usually have got a higher what you call levels as compared to the adults one, but any child who has got more than 1000 picograms per ml of BNP, that correlates very well with the moderate and the severe classes of heart failure. There are age specific cutoffs, like for example less than 1 year, they can have a value anywhere between like 30s to 600. As they grow up, the values slightly go down, like between 20s and to like 300s, but like obviously you have to look at these values in the realms of the context of the age, but in any case more than 1000, the level is correlates very well with class 3 and class 4 ROS, class 3 and class 4 heart failure. Then there is some role for genetics as well in pediatric age group, because there are certain types of syndrome which might be associated with cardiac failure, and there are different types of genetics or genetic testing that can be done for these kids. But the main hallmark investigation is pediatric echocardiography, because it gives you not only the anatomy, not only visualizes the anatomy of the heart, it also gives you the volume and the pressure gradient. So that is one like non-invasive investigation, very sensitive, very specific for pediatric heart failure. And if there are, let's say you want to go one step further, then we have got the cardiac MRI, which actually gives you the quantification of the fibrosis in the cardiac muscle, if any. As far as the management is concerned, the medical management, number one, in acute heart failure. And acute heart failure means acute decompensated heart failure, where there is volume overload, there is plethora, there is too much like of a volume congestion in the body. We always use our old time tested trend, that is a loop diuretic furosemide, and a dose of 0.5 to 2 milligram per kg per dose. It inhibits the sodium potassium chloride co-transport and like moves sodium out and moves water out of the body. So that's usually used in acute heart failure. But the mainstay of the treatment are your ACE inhibitors. In neonates we use the captopril, in older age group we use enalapril. The doses are like different for enalapril and captopril, but again these are very safe medications, and they not only cause vasodilatation, they also improve the cardiac output. And then we have got the beta blockers. Beta blockers are never used in acute heart failure. They are used in stable heart failure, especially those who have got let's say increased systemic filling pressure, diastolic sort of a dysfunction, and carvedilol, which is a non-selective beta blocker, is used in this regard. Then we in the 2025, like the Panorama heart failure trial has sort of what it has done is that it has proven the role of ARNI, which is actually a combination of valsartan, which is the ACE receptor blocker, along with sacubitril. And sacubitril is basically a neprilysin inhibitor. So neprilysin basically is an enzyme which is released by the myocytes, the damaged myocytes. So it inhibits that. So what it happens is that it increases the life of the myocyte. At the same time, it's got an additional benefit of blocking the renin-angiotensin-aldosterone system network. So it's given in a combination of given like these two medications are combined together, and they are given at a dose of 1.6 to 3 milligram per kg per dose twice daily. But if you are using ACE inhibitors, you have to need a washout period before you switch over to these medications. And then we have got certain other adjunct medication like ivabradine, which increases the exercise tolerance. We have got the SGLT2 inhibitors, which have got a very like a high role in adult heart failure. These are anti-diabetic medications, but they have got like mortality reduction benefits. They also improve the heart myocyte function. They reduce the mortality because of heart failure, and they are used in the elements, and the recent trials have shown that they have got a role in pediatric heart failure as well. And then we have got the very Seguard medication, which is the SGC stimulator, and certain trials have proven that it is also it's also very beneficial in pediatric heart failure. Then at the same time, one thing which is usually overlooked is the role of nutrition in this, because these kids, they are faltering, they do not have a great appetite, so they have to be given condensed or dense nutrition. So either you might have to add carbohydrate polymers to their nutrition, they have to be given multivitamins, or you might have to go through other routes like PEG tubes or enteral nutrition to build up so they are getting enough nutrition. This is a hypercatabolic state, so they need more nutrients than what a normal child would require, and usually we estimate that 110 to 125% of the normal intake is usually required by these kids. Then if we move on to when, if let's say if the medical therapy fails, then the next is like giving them some form of support. So if they are acutely unwell, we have got supports like the ECMO, extracorporeal membrane oxygen, that can use for days to weeks, and that takes over the function of the heart and lungs, and buys you sometimes. And if it goes into chronic one, then we have got the ventricular assist devices. These are mechanical devices which actually pump the blood. They take the job of the ventricles, and they can be used as a definitive device, or they can be used as a bridge device if you are going for a cardiac transplant. So some of the devices that are used is the extra what we call as the paracorporeal devices, the ventricular assist devices like the Berlin heart X-core, which the pump sits outside the body, and like it does the job of the ventricles, but it's got like high complication rate like stroke and thrombosis. Then we have got the intracorporeal ventricular assist devices like HeartMate 3, which are implanted inside the body, and the child can carry a battery in his rucksack and something which like helps running the device. The definitive treatment is heart transplantation, but heart transplantation has fraught with its own risks because you need to have an HLA matched donor. This child needs to be on lifelong immunosuppression, can develop graft versus host reaction, and obviously there are certain indications. If a child has got irreversible pulmonary hypertension, active infection or malignancy, then you can't go for heart transplant, because that would be like beginning of the end. So there are certain conditions that has to be met before you go for an HLA matched heart transplant. But as I said, like as the new devices are coming up, that is decreasing the role of the heart transplantation as the definitive treatment for pediatric heart failure. So remember, in general, it's the recognition of the sign symptomatology in pediatric age group, because that very much non-specific as compared to the adult one. We use the Ross classification, we use the medical treatment. If the medical treatment fails, we go for the surgical or the type of devices that are used as mechanical hearts. So this was all about a small lecture about the pediatric heart failure, its definition, causes, classification, medical and non-medical management. Hope you have learned something new. If you got any questions, put it down in the comment section below. And if you haven't subscribed to my channel, what are you waiting for? Subscribe, like and share it with your friends. Have a very good day. Take care and bye-bye.